posted on the BC Renal website. So here we go. Next slide, please. So I want to acknowledge that many of us, but not all of us, are here on the land that we host this session, which is the unceded and ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, the Squamish, the Tsleil-Waututh Nations, the Métis Charter Community of the Lower Mainland. And we endeavor to both learn with and from our colleagues and try and right many of the wrongs and address so many components of truth and reconciliation. And by learning more about kidney diseases and their interaction with land and genetics and environment, and how we then, to today's topic, personalize things is part of our endeavor. So thank you for all reflecting on where you're from and what we do and how we can do things better. Next slide, please. So Province-Wide Rounds is a collaboration between UBC Division of Nephrology and BC Renal. It's supported by a number of industry partners with unrestricted educational grants, as well as all of you in the different health authorities by virtue of the topics that you choose to listen to, the way you get educated, but also the programs of work that you do within the quality improvement and research spheres that help to advance our knowledge. So thank you all. Next slide. So today we have Dr. Matthew James and Dr. Todd Wilson from the University of Calgary with us. Many of you will know Dr. James, but I'll just remind you that he's a professor of medicine and a clinician scientist at the Department of Medicine and Community Health Sciences at the University of Calgary. He actually did his medical training here at UBC and completed nephrology and PhD in epidemiology at the U of C. And he's currently the co-lead of the Alberta Kidney Disease Network and the Interdisciplinary Chronic Disease Collaboration, ICDC, as well as a co-lead on the CanSolve CKD SPORE network. He's also the Director of Research for the Alberta Provincial Project for Outcomes Assessment in Coronary Artery Disease, which is otherwise known as APPROACH. And he's done a lot of work on risk prediction, computerized decision support, and pragmatic trials. And he's joined by Dr. Todd Wilson, who's a statistician, PhD statistician in epidemiology at the University of Calgary, with research focus on statistical risk prediction tools for kidney and cardiovascular outcomes, and looking at research methods to understand patient preferences and values, which is important in this world of personalized medicine. And he certainly collaborates with a number of different multidisciplinary teams, including the APPROACH group and CanSolve CKD, as well as the Alberta Kidney Disease Network and the Clinical Nephrology Research Group. So with that sense of who's speaking with us this morning, I'm going to hand it over to Dr. James and Dr. Wilson, and again, encourage everybody to have questions and think about how this applies to things that we do. So over to the two of you. And thank you for making time on a Friday morning.
Thanks, Adira. Thanks for having us. I'm going to start the talk with a bit of background and then pass it over to Todd really to delve into the methods of the work we've done. And then it'll come back to me at the end to kind of tie things together. And Todd's navigating the slides. Thank you already for the land acknowledgement. Just to extend it a little bit further east, Todd and I would like to acknowledge that we're on the traditional territories of Treaty 7 in southern Alberta, the Blackfoot Confederacy, that includes Siksika, Piikani, and Kainai First Nations, as well as Tsuut'ina First Nation, and the Stoney Nakoda, including Chiniki, Bearspaw, and Wesley First Nations. And the city of Calgary is also home to Métis Nation of Alberta, Region 3. Next slide. We really don't have any important financial disclosures related to this talk. And go to the next slide, which is really the objectives. What we wanted to do in the talk today is share some of the work we've been doing on developing, validating in Alberta as well as British Columbia risk prediction models for people who have both kidney and coronary artery disease. We want to also broach this topic of how we incorporate and understand patient preferences, particularly related to the use of invasive procedures in this population, and how some of the work we're doing is hoping to increase our understanding of how we incorporate this into decision making. And then finally, we're going to try to wrap it all together or weave it all together, talking about how we can incorporate some of the work we've been doing on understanding the variable risks for cardiovascular outcomes and kidney outcomes of people with kidney disease and the varying patient preferences within a shared decision-making framework that is really delivered through a decision aid that we've been working through the CanSolve CKD network to develop over the past few years. So we'll start with a bit of background, and this is some work from a few years ago now in Alberta, looking at the outcomes as well as the risk of myocardial infarction in people with kidney disease, comparing that to people with diabetes and people with known coronary artery disease identified by having a myocardial infarction in the past. And the top panel here of this figure is showing the incidence of myocardial infarction, and the bars group it across a number of groups. And on the far left is actually the incidence around people who have known established coronary disease. These people are identified by having a myocardial infarction in the past. And you can see they're the highest risk group for having another myocardial infarction. But the green bar actually identifies people who have chronic kidney disease and diabetes. And there you can see that their risk is almost just as high as people who have known coronary artery disease. It's a very, very high risk group. The red bar is people who have diabetes without chronic kidney disease, and you can see, or sorry, chronic kidney disease without diabetes. And you can see that this group is also at quite elevated risk, followed by those with diabetes alone. And then on the far right is the group of patients without any of these conditions, no diabetes, no kidney disease, no prior history of myocardial infarction. So this isn't, I think, surprising to this audience. We know people with chronic kidney disease are at very high risk for coronary artery disease and related events. The panel below looks at all-cause mortality for these groups after a myocardial infarction, and you can actually see the green bar there. The population of people with diabetes and chronic kidneys are actually at the highest risk for mortality after one of these coronary events. This is work from the CKD Prognosis Consortium that looks at the risk of cardiovascular mortality across the range of eGFR values on the left, across a range of urine albumin to creatinine ratios on the right, really showing the relationship between more advanced stages of chronic kidney disease based on GFR or albuminuria independently and their relationship with adverse outcomes. And you can see here that there's very strong relationships with cardiovascular mortality as well as cardiovascular events that exist as GFR declines. And this incidence range is more than fourfold from the earliest stages of CKD down to approaching stage 5 based on GFR. And we see a very similar pattern of rising cardiovascular mortality with increasing urine albumin to creatinine ratio. Again, an over fourfold increase in the magnitude of risk as this increases. And coronary artery disease actually is one of the earlier cardiovascular conditions that is identified among people with chronic kidney disease. This is a schematic really showing the range of cardiovascular diseases that we encounter with people with chronic kidney disease. The orange is showing the atherosclerotic coronary artery disease. The purple is showing additional cardiovascular outcomes like arrhythmias, sudden cardiac death, valvular disease. The green below is showing that risk of mortality following cardiovascular events. But you can see that it's actually coronary disease tends to start to increase very early in early stages of chronic kidney disease. And then it's really common and kind of maintained in its incidence and prevalence throughout stages G3 onwards. This is an interesting study just to kind of introduce that we know there's a couple different ways at the high level that coronary artery disease can present. Some patients present with acute coronary syndromes. Some present with chronic coronary artery disease with symptoms of stable coronary disease or symptoms or findings on imaging or the workup of in various aspects of their care, including the process of working up for a kidney transplant. What this study does, it looked at the different types of presentations, comparing how frequent was it for people with different levels of kidney function to first present with chronic stable coronary disease versus an acute coronary syndrome. What's interesting here is, generally, once the people's GFR was below 45, the likelihood of presenting with an acute coronary syndrome became much more common than initially presenting with stable coronary disease. Between 2 to almost 3-fold higher likelihood of first presenting with an acute coronary syndrome. So this is quite a common way we end up seeing coronary artery disease present in patients with chronic kidney disease. As Adira mentioned, we've been doing a lot of this work with the CanSolve CKD network. And really this project has its roots and origins going back to the very beginning of CanSolve, and even prior to the initial funding of the CanSolve CKD network, when a series of patient priorities for research exercises were done in people with kidney failure, as well as people with early or stages of chronic kidney disease. And within both of these groups, speaking in workshops with patients and their care providers, the research questions related to how do we improve identification and management, treatment, prevention of heart disease and cardiovascular disease came up as important priorities for both of these groups. So this really started us on some of this journey to do some more work in this area to try to improve our approaches for diagnosis and management. We're not going to spend much time on the medication management today, because this project is really focused more around decision making, around the treatment approaches related to using invasive tests and procedures for diagnosis and management of coronary disease versus medical management approaches. But I think we have to put all of this in the context that we do have a number of medications that have increased over the last few years that have been shown to have important cardiovascular and coronary disease prevention approaches. So we do have really an armamentarium now of medical therapies that we know are effective in patients with CKD to lower the risk of cardiovascular disease and coronary disease in particular. But what we'll shift to now really for most of the rest of this talk is this decision making around choosing the invasive management versus a medical management strategy for coronary artery disease. And this has been studied extensively and increasingly in the last few years been studied specifically in people with chronic kidney disease, because as we know, there's some unique considerations related to procedures that are specific to people with kidney disease, related to the potential for kidney injury and the effects that can have on outcomes that are particularly salient for people who have chronic kidney disease to begin with. So this is kind of the direction we'll go from here. I mentioned we now have quite a bit of evidence from trials, and I'll start in the chronic stable coronary artery disease space, because about 5 years ago now, the ischemia CKD trial was published. So the ischemia trials were large randomized controlled trials that were done in people with stable chronic coronary artery disease. There were some important exclusions from these trial populations, like people who had reduced LV function or known to have particularly high-risk coronary disease based on imaging. But essentially what these trials did is randomize patients to an routine invasive strategy versus a routine medical strategy. There was an overall ischemia trial done in the general population that excluded people with CKD, defined as a GFR below 30, or treatment with dialysis, also excluded people with a transplant. And then there was a specific CKD sub-trial that was enrolled people who had CKD with a GFR below 30 who were on dialysis. And this primary outcome of the ischemia CKD trial with death from any cause or MI, which is shown on the left, and then the secondary outcomes were a bit a broader set of cardiovascular outcomes that included myocardial infarction, hospitalization for unstable angina or heart failure or cardiac arrest. And what the ischemia CKD trial showed is this routine invasive strategy conferred no improved outcomes in terms of these primary or secondary outcomes. And if we go to the next slide, the top panel here is comparing the outcomes from the ischemia CKD trial to the broader general population ischemia trial. And really the findings were very similar. In both trials, this routine invasive strategy was not beneficial over the conservative strategy. Now, some patients in the conservative strategy did end up, crossing over and receiving treatment with invasive procedures if they failed medical management. And that's really what conservative management means. It speaks to the initial strategy that is undertaken, recognizing that there may be changes, whether patients develop complications or the initial management strategy isn't successful. But what this figure, although there's no difference between these different treatment groups, this figure does highlight how common these outcomes were in CKD. The scales and the time of follow-up are a little bit different between the two figures from the two different trials. But if you follow them out to, a common time point, that the incidence is about 4 times higher of the primary and secondary outcomes of the population in the ischemia CKD trial. There was, a bit of a concerning safety signal that is seen in the ischemia CKD trial amongst the subpopulation in the trial that were not already receiving kidney replacement therapy. They did follow this group to see what their hazard of kidney failure requiring treatment with dialysis was, and they did see this signal of increased risk. It was statistically significant when you looked at all-cause death or initiation of dialysis in this population. The ischemia CKD trial and the ischemia trial in general both looked at health status in a sub analysis within this trial. I'll just highlight here the Seattle Angina Questionnaire results, which focus on symptoms of ischemic heart disease. What you can see here is actually in both groups, regardless of the management strategy, there was improvement in their symptoms. So their symptoms improved, and going up here is less burden of symptoms as the SAC score increases. So they got better in both groups, whether they were medically treated or treated with invasive management. And overall, there was no significant difference in their health status over the course of the trial. This next slide is very kind of busy, but there are, when you dissect out a little bit of the subgroups, it suggests that there might still be subgroups of patients who do experience improvement in their symptoms or health status with invasive procedures. So the panel on the left shows, the change in or the difference in the health status measures between the two treatment groups overall in the trial. And then as you move down a column, it's showing at different time points. So it's showing what's the difference between the invasive and the medical therapy group at 3 months, 12 months, and 36 months. And overall, you can see that distribution of scores shifts a little bit to the right of the line of null effect at 0. So there is overall a bit of an effect being seen, but that wanes over time. And by the end of a year or onwards, there's really no difference. And if you then move to the second, third, and fourth columns, you can see, these results stratified by the burden of symptoms that patients had at baseline. So the second column here is people who are having very frequent anginal symptoms. The third column is kind of monthly, and then people who are really asymptomatic are shown on the far right. And what you can see is really the group that seems to be experiencing this improvement, at least early with this type of intervention, is those who have quite a significant burden of symptoms at baseline. This shifts to just summarizing what we know about invasive procedures for people with chronic kidney disease presenting with acute coronary syndromes. This was a meta-analysis, patient level, that took the subgroups of patients with CKD from the early invasive versus conservative management trials for acute coronary syndrome. The left panel is a forest plot looking at the outcome of death, comparing invasive versus conservative management, and the right panel looks at the outcome of myocardial infarction. And you can see here that the overall pooled estimates, in the ACS population with CKD does show a signal of benefit, a reduction in mortality and myocardial infarction for people with CKD presenting with acute coronary syndromes. And this effect size, about a 20% effect size, is consistent with what this literature shows in people without CKD from these trials. And if you go to the next slide, this was an observational study that we did in Alberta, looking at, matching using propensity score methods, people who were treated with invasive versus conservative management for acute coronary syndrome, really showing at the bottom panel for people with a range of different GFRs here, shown that we saw very similar relationships with lower mortality in the people who had invasive management in the setting of acute coronary syndrome. But on the top panel, you can see there is an increased risk of acute kidney injury, and acute kidney injury requiring dialysis for people who received the invasive management approach. So in terms of guidelines currently for acute coronary syndromes, generally, routine invasive approaches are suggested for people who are at high or intermediate risk. But there's caveats in the guidelines around people with chronic kidney disease, particularly advanced chronic kidney disease not on dialysis, that's called out in the table that's shown on the right, as well as the issue of patient preferences being brought up in this decision-making process. And if we go to the next slide, this is the guidelines for chronic stable coronary artery disease, which actually promotes a shared decision-making approach where decisions are really driven by symptoms assessment and quality of life, and a discussion of treatment options and patient preferences that are used to arrive at what the most appropriate management would be for an individual patient. And actually within this shared decision-making framework, they do actually call for the use of decision aids to help support shared decision-making. And this is what's in the most recent KDIGO CKD guideline, suggesting that for stable coronary heart disease, a medical management approach is appropriate over an invasive management approach, but with practice points that indicate there may be situations such as in acute coronary syndrome with significant levels of angina, or some of these conditions that excluded people from the ischemia trials where this would be an appropriate treatment approach. And these are graded as suggestions rather than recommendations, recognizing the uncertainty and the fact that patient values and preferences are likely going to influence the decisions for individual patients in these areas. This is a study from the United States from several years ago that looked at how decisions are made in people who are admitted with acute coronary syndromes, and asked patients themselves how they felt the decisions should be made. And what the blue bar on the top is showing that most patients, even in this context of being hospitalized for a myocardial infarction, said that patients should play an active role in their decisions. They didn't feel these were just should be playing a passive role in the management decision that was being made. And the bottom panel really breaks that down a little bit further to show within that group who said patients should be actively involved, really this was a shared decision to be made, in collaboration between the physician bringing their expertise and the patient recognizing their values and preferences. And on the next slide just summarizes some of the initial work that we did at the beginning of this project to try to understand this further, specifically among people with chronic kidney disease who'd had a coronary event, as well as mainly cardiologists who'd been caring for them. And we really delved into kind of understanding the role of shared decision making, and it was valued both by patients and healthcare providers, but there were many barriers to actually being able to successfully implement it. there was uncertainty around being able to communicate, appreciate, specific risks for people with different stages of chronic kidney disease and how to share that with patients. Physicians felt it would be helpful to have more tools to help share this information. At the same time, they felt they had a lot of expertise that they could help guide patients in making these decisions. So this kind of started us off on this project, which we've now been working on for several years, which is really focused in those two areas of trying to provide patients and their care providers with better estimates around what their risks of kidney versus cardiovascular outcomes are with different treatment approaches, and how we should approach the issue of patient values and preferences, and do they range? Are they all consistent? How do we incorporate this into care decisions? So with that, I'm going to turn it over to Todd, who's going to take us through a lot of the work that he and others have done in this area.
All right. Sorry about that. I was still on mute. Yeah, thanks, Matt. So I'm going to first go through what we did for assessing patient preferences. And some of you might be familiar with a discrete choice experiment, but probably not everyone. And so what it is it's a stated preference methodology based on utility theory, where the attributes of a treatment option contribute to its utility or the value that patients or participants find towards each individual attribute. And so it's a survey where respondents are asked to choose between two or more options, and they have to trade off the benefits and the risks of the attributes. And that's all very theoretical. So let me show you exactly what we did in terms of the survey. So this is one question that a patient or participant would face within the survey, and they get 8 to 10 of these. And what the attributes are in green on the left side, and these stay the same from question to question. And what changes is the blue boxes or the treatment from question to question, and patients have to trade off what's important to them versus the benefits and harms of each treatment. And what we can do is we can gather this data and we can quantify patient preferences, and then with that we can see what's important to patients and work from there. And so this is an example of the data, or this is the data we got from this survey, where we had 140 people with CKD were asked, towards treatment preferences for acute coronary syndrome. And what we can see here is overall the most important attribute was death, followed by kidney failure. And what we see here is it looks like treatment approach is not very important overall. However, I'm going to skip past this slide. When we do a latent class analysis where we search for preference heterogeneity among the data, we can see that there are two distinct groups with quite different preferences. The larger group with 115 patients was aligned with the overall, where death was the most important, followed by kidney failure. However, we found this group of patients where treatment approach was by far the most important, and they placed the most utility on a conservative management approach. And so this really highlights how eliciting patient preferences can be really key for shared decision making. And I'll just go through here. Within the latent class groups, those two groups we found, nothing really stood out among the characteristics that we collected in terms of differences between groups. But there was a few, and one of these being the EGFR among the group. The procedure averse group did have lower EGFR, so more severe CKD. And a larger percentage has actually been to dialysis modality education sessions. So maybe taking away some of the fear or misunderstandings around dialysis. And then also with this group, in terms of their goals of care, we asked about that. And more people in this group had chosen no resuscitation in their goals of care. So there was some differences between these two. Another piece of the information we can get from the discrete choice experiment is called the marginal rate of substitution. And what that is we look at the relative importance of one attribute another, and that being what are patients willing to trade off from attribute to attribute. So these numbers look at how much of one attribute will a patient accept relative to 1% decrease in the risk of death. So what this is saying is patients would accept, for example, a 1.9% increase in the risk of dialysis for a 1% decrease in the risk of death. And I won't go into too much detail on these, but we'll get into it a little later. So I'm going to move on to the second part of the project where we developed and validated risk prediction models for cardiovascular disease and chronic kidney disease. And so it's a series of models. And so we started with patients with CKD who had been hospitalized for non-ST elevation, acute coronary syndrome, or patients diagnosed with stable angina. And our outcomes were estimated risk of over 1 year of all-cause mortality, readmission for MI, or admission for MI in the stable angina population. We had a composite outcome of death and readmission or admission for MI and kidney failure. And then we also had a 30-day outcome of acute kidney injury requiring dialysis. So the inclusion criteria for these were 18 years of age and older. They had a hospital admission for NSTEMI, ACS, or a diagnosis of stable angina. And then we defined CKD as 2 measures of eGFR separated by at least 90 days, being less than 60, or 2 measures of ACR being greater than 30. And we excluded patients who were on dialysis, had a transplant, or had a sustained eGFR less than 10 over 90 days prior to their hospital admission or diagnosis. So we used Cox proportional hazards models for the mortality and composite outcomes. And to account for the competing risk of death, we used fine and gray subdistribution hazard models to estimate risk as readmission for MI and for kidney failure. And for the AKI outcome, we used logistic regression. These are the predictors we included in the models: age, sex, and treatment being invasive versus conservative, lab measures, eGFR, albumin, urea, hemoglobin, and then we included these comorbidities, Charlson comorbidities. And we also included whether or not a patient had had a prior invasive procedure. And so what this does is these models provide us a basis for personalized risk prediction. So for our development cohort, I did this using a general population of patients with CKD in Alberta from April 2004 to March 2017, and it gave us a little under 12,000 patients. And then I also did a temporal validation for a later time period in Alberta to assess model performance and update as necessary. And I won't go into that here, because mainly we want to show you the external validation we did using data from BC and with great help from Lee Earth. Thank you for that. And here we used the cohort of patients here was slightly different in that these were patients who had been referred to nephrology in BC from 2004 to 2019. And this cohort was around 1,800 patients. And so we used this cohort to assess model performance and update the models as necessary. We looked at discrimination and calibration through this analysis. And I'll just go through some of the models here. And what this is so this is the model for death within 1 year. And when we initially applied it to the BC cohort, you can see that on the left, this is the baseline survival. And the text is a bit small, but our model was underestimating the risk in the BC population, which makes sense considering it's a group with more severe forms of CKD. The middle panel is kind of a combined discrimination and calibration plot, and the we can see that the model and the observed risks don't quite align here, and the rightmost panel is a straight calibration plot showing deviations from perfect calibration being the black diagonal line. And with this model, initially, we had a C-statistics of 0.71 and calibration slope of 0.83. Now, when we update this model, we update the baseline hazard function. So we can see on the left panel that aligns now. And we also adjust for calibration slope. And you can see in the middle panel, we're now aligned between observed and expected. And the rightmost panel, and we're right on with calibration. And I'm just going to quickly go through, in the interest of time, the next few. So we had readmission for MI. This one really didn't fit very well initially. C-statistics of 0.57, calibration of 0.51. When we update it, we do get some separation in terms of discrimination. You can see in the middle panel, and the calibration slope is quite good. Sorry, that should say the calibration slope of 1 at the bottom, not 0.51. Similarly, for kidney failure, it didn't fit quite well. And then when we updated it, it was quite close. And so the next part of the project I'll move on to is with these models, we want to account for treatment selection bias, this being observational data. We don't know why people are selected for treatment. And so what we've done is we use data. Oh, my apologies. We adjust for treatment effects from RCTs, and then we tried to combine the results from the DCE with the risk prediction models, that being those marginal rates of substitution. And our goal is to estimate a patient preference adjusted net benefit equipoise or net harm between a conservative management or invasive management strategy. And there's a lot of numbers here. This is just an example of the calculation we did to determine net benefit, equipoise, and net harm. And so I've highlighted here just the net benefit example. But what's more informative, I think, than looking at the numbers is the next figure here. And so what this is showing is for each patient in our cohort, whether they would receive a net benefit from an invasive management strategy, or whether we weren't really, you weren't sure, it's either equipoise or net harm. And in terms of net harm, it's like across the bottom axis is kidney failure events per 1,000 patients, whereas on the left side, this is the composite events for 1,000 patients. So we can see some people in red, really would experience net harm from an invasive approach, and these tend to be those with much more severe forms of CKD or maybe older patients or those with multiple comorbidities. But the majority of patients we found will experience a net benefit from an invasive management approach. And so I'll hand it back to Matt now, because this is we used the data from these studies and we combined it together to develop a patient decision age that we can use at the bedside for patients who are with CKD who are facing a treatment decision for acute coronary syndrome or stable angina.
Thanks, Todd. So that last figure that Todd showed, kind of tries to model out these groups of, identifying people who would potentially have the most likelihood to benefit, the group who highest likelihood not to benefit or to have unclear benefit. But this is across synthesized across a large group of patients, and every patient is going to have an individual risk and an individual personal set of values and preferences. So really we wanted to move this down to the level of the individual, incorporating the personalization from the risk models, addressing the values and preferences that are unique to an individual person. And so to put this all together in a way that synthesizes our best evidence from randomized controlled trials and the most personalized estimates of these risks for an individual patient from these models, we took some of these modeling approaches. We worked within the framework of developing and using best practices for patient decision aids to create this decision aid called MyHeart and CKD, which is for patients specifically with CKD who are contemplating the management strategy, invasive or medical, under these two different scenarios, the acute coronary syndrome scenario or the stable chronic angina scenario. We went through this iterative process to design and develop the decision aid using a human-centered design and development approach. Essentially, where what we did is we work with a group of patient and healthcare providers in an iterative manner to design the decision aid, develop mock-ups or initial versions, get feedback on them, refine them, and take them back to more patients and healthcare providers, respond to the feedback we get. And basically, along this process, the tools become more sophisticated. They focus in on the areas that are identified to be most important, and they really move from essentially mock-ups to a final product. And this just reflects the many stages of this process. We really took 3 rounds where, we took the information we had from these studies, developed an initial mock-up, reviewed it with patients and healthcare providers, took the feedback, went back, refined it, and then went back to those stakeholders again to refine it. So after these final 3 rounds is what it took us to develop this decision aid. So these are just a few screenshots to show what it's like. Our final version is now being developed. It's available as a web application, so you can go and use this now. It is available online. We are just in the process now of adding in the updated data from the validation in BC to reflect, some different sort of patient population, a higher risk population, like the referred population from BC. Right now we have the general CKD population from Alberta in the tool, but this will be updated soon. Essentially, the way it works is, the healthcare providers and the patients are intended to work through this together. There's a number of different ways that can be done to kind of integrate it into the workflow. But the first step there is to decide which type of coronary disease syndrome the decision is related to. And that takes you down different arms of the decision aid related to those conditions. And then part of shared decision making and decision aids is to be very clear initially about that there is a choice, that there's options, and describe what those options entail. And so there's a section here where the 2 choices are outlined. And then if you go to the next slide, you can click on those details areas and get much more information about what invasive management means. What does optimal medical therapy entail for patients, so they fully understand, the attributes of the different choices they have. This, as Todd showed you, we really built this decision aid with personalization in mind. Some decision aids would give you overall population attributes in terms of risks or benefits of a tool. We knew that these risks are really highly variable across different stages of chronic kidney disease. So we used the models like Todd described to be able to personalize the risk estimates integrated into the tool. So this just shows how at some of the initial stages actually do require, some specific information related to kidney disease and comorbidities to get the most relevant personalized information out of the tool. Then it moves on to actually describing the attributes with the different treatment choices. So the outcomes for invasive management are shown on the left, with optimal medical management are shown on the left. These integrate the baseline risks according to the individual personalized preferences from the models Todd described. But then the treatment effects are adjusted based on what is known from randomized control trials. So the differences here actually reflect evidence from from quite high quality studies. It's presented in a number of ways consistent with best practices for decision aids. So there's a number of different ways of conveying absolute risk differences to patients, both as numbers, as visuals, as icon arrays, kind of shown down here, to make the differences clear. So we show, those reduction, the differences in survival and recurrent myocardial infarction. We also show the risks of acute kidney injury requiring dialysis and kidney failure requiring therapy. The last section also gives patients more information about what does invasive management entail. So what is the probability that means an angioplasty? What is the probability that means open heart surgery or CABG? What is the probability that you still just, have a diagnostic testing but are treated with medical management? So that's really giving patients the knowledge around the attributes to inform their decision making. But coming back to the earlier points about values and preferences, we designed a specific aspect of the tool to open up and ensure communication and understanding around values and preferences is incorporated into the decision-making process. So this formally takes the patient with their healthcare provider around some questions related to their values and preferences and asks them to think about these and rank them. And then we hope that this actually broaches and opens this up into the shared decision-making process, that values and preferences are explored and discussed between the physician and the patient. And then at the end, we ask some questions to see how confident the patient feels at the end of this process, whether they feel they need more information, whether there are other people in family or caregivers that they want to discuss this with. So we have the user has a sense of where the patient is at the end of this process, and if they're confident in making a decision or more assistance is needed. So that's a very quick overview of how the decision aid works. What we're moved into now in the current phase of our project is actually starting to implement and evaluate this decision aid in practice. So we've designed this pilot implementation trial that we've now just started in Alberta. So what we're doing is starting to measure across 10 cardiology practices. This is going to be done in practices across Alberta, BC, Manitoba, and Quebec, where we start to actually measure the patient experience and decision-making experience with some particular measures related to shared decision-making. The primary outcome here is decisional conflict in these scenarios, and then secondary outcomes are measures of shared decision-making, knowledge, accuracy of risk prediction, and whether treatment choices are congruent with patient values. And so we'll, in this cluster trial across these 10 practices, we'll be measuring these factors before the use of the decision aid, then introducing the decision aid, and then measuring them again to see if this actually impacts these aspects. And I think that brings us really to the end of the talk with some time for questions and discussion around this. Just to thank a number of people who've helped us in this work, particularly, as Todd mentioned, Lee who's been critical in the work of expanding the validation and updating and using data from BC. So thanks very much for all that work, Lee, and Peter and Adira as well for helping us make that happen. There's a large team in Alberta that's really helped throughout this work, acknowledged here, and funding, particularly from CanSolve, CKD Network, through CIHR and matching support from the Living Institute, as well to help this work, and from BC to BC Renal and Cardiac Services BC for allowing us to, and Population Data BC for allowing us to use data from BC for model validation and updating. Thanks.
Thanks, Matt and Todd. Maybe you can stop sharing because that way it's easier to see.
Yeah.
Thanks. Happy to answer any questions either in the chat, or you can raise your hand and Eamon will unmute you. I guess a couple of just practical questions, and is in terms of language, is this only like number one, is it only in English, and is it easy to translate? And in terms of, and number two, I've heard different things about like all of these aids are great, but I think you still have to have them curated by your with your healthcare professional. Like, is it intended that the patients do it by themselves or along with their healthcare professionals?
Yeah,
In
thanks
terms
for
of
those
practical
questions. Yeah,
implementation.
thanks, Yadira. Yeah. So the language issue is important because, there is some literature about, we intend these decision aids to be helpful, but if we don't make them accessible, they might benefit some groups more than others. So what we did is the way we designed it is it the way everything is entered is you can use the Google Translate function. So it will translate into all languages that Google Translate supports across all the pages. So essentially it's just built in a way that allows it to totally leverage Google Translate function. So that's probably the best way to use it is in the Google Chrome. And then you can have any language you like. The only thing that won't translate is like the little things that are embedded in an image, but everything else is text-based that can translate over. And then we've had a lot of discussion around like how do we want people to use the decision aid? There are models where decision aids are just given to patients separately outside of their discussions with their care providers. Sometimes it's done beforehand. There is models where shared decision making is actually an interactive process with your healthcare provider. Victor Montori has great videos showing, like doing decision making in person with a physician using decision aids. He has cards that he asks questions and then uses these cards. We really wanted this to be used together, but we also recognize that can be challenging, to incorporate into workflows. So we've tried to be flexible on how it can use. We're trying to promote using it with the patient and setting it up that way. But actually, there's various ways you can kind of enter the tool and use it so that some things can be set up before a patient visit. It can at the end, if a physician and patient are using it, they can print it all out and have a summary of everything as a printout because some people just like having it on paper as opposed to looking at a computer screen. So we're trying to be, balance that, be practical and flexible and let people use it in the way they can fit it into their workflow. But we are trying to promote it being shared decision making where there is this is a tool to facilitate those interactions between the patient and their care provider.
Yeah, I guess, and in Calgary, are you finding that like, I guess we have to also socialize it, right? If the cardiologists don't know about it, and their usual say is if you got a 50% chance of ending up on dialysis.
Yeah.
If I do this procedure, it's like.
So we're really targeting the implementation with cardiologists. That last trial is really targeted for the cardiologists. Those are the 10 practices we're focused in are cardiology practices.
Right.
They're really the group we're
But
targeting.
we should know about it as well as nephrologists.
Yeah.
Daniel put a question in, do you think the patient preference would be impacted by a longer time horizon? So instead of saying within this year, if you said in the next 5 years or something like that. So I think it's an interesting question. Probably I can't think about next week, let alone.
Yeah, that's a great question, Daniel. I think preferences might shift over that time, and maybe mortality may have slightly lesser importance, where patients start to think a longer time horizon, they're maybe more concerned on their quality of life. So there might be a higher preference, say, towards avoiding dialysis or even the other non-mortality outcomes might become a bit more important in a patient's eyes.
Yeah, no, I think that is a good question. And, I think one of the things, there are so many tools and so many predictions out there. I think that one of the things is if we can figure out how best to use it. I certainly, in many instances, I think patients are inundated with apps and pieces of paper and questionnaires. So my totally biased perspective is that they're more likely to engage if it's someone with them. And I would say it's either the cardiologist or the nephrologist or their primary nurse if they're such an animal, depending on, you know, what your system looks like. But I think that would make it probably more understandable because you can nuance it differently. So yeah, no,
And
I
there's
think
questions
it's
that the
really
decision
interesting.
aid can't cover everything.
Right.
And part of the idea, I think, is it does open up the opportunity for questions. And then you want to have somebody with the expertise there to
To be able to answer,
respond to
yeah.
those. So yeah, I think that point is well taken.
Yeah, any of my other colleagues, I mean, I'm going to try and channel what I think people might ask is, you know, I think you talked about workflow, right? But, you know, like I've always said, like if you have a structured way to ask questions and a structured way to capture the answers, that shouldn't add work. That should just improve your ability to standardize the questions and the answers. And I think I don't know how well we help each other adopt that because there is this resistance amongst, you know, physicians and nurses and others. Well, I'm going to ask the questions anyways. Why do I want to use this tool? It's, well, you don't have to ask the questions in this nebulous way. You can ask them this way. But I don't know, have you come across that or had conversations about that locally?
That's a common thing that comes up is how much time is this going to add to my day or my visit? We're still trying to explore that. We're measuring that within the trial to try to understand that. There is literature on this across the decision aid literature, and it's surprisingly small when you read what is summarized. It's just over a minute, is what's been captured in studies. It seems strikingly like small,
Right.
but maybe it does replace, you know, like maybe you're right. Maybe by doing some of these things in a structured manner, you don't do it in
That
a
would be
less
that would
efficient
be a
way.
good experiment, you know, like sort of
Yeah.
have people do what they always do and then have people just do this and see if it doesn't take away from the humanness, it just structures it. There's a question about, and I think you probably have done this, but has the text in the tool that patients read been reviewed for plain language and health literacy?
Yes. Yeah. That was a really important part of the developing this. And it was really challenging just with this topic. Like there's so much lingo and descriptions of procedures that we use like all the time. And
Yeah.
so we did a lot of that work. I would say like it's improved a lot through our process, although it's probably like, you know, we got it down to grade 9, I think, is what it ends up being. But like we're on the kind of the high end of language complexity that you
Yeah.
want to be
I was
on
noticing,
it.
I was reading, I was like, oh, I might
Yeah.
like take it to yet another, but yeah. We're almost at time. I think that's all the questions. I'll just do another scan. So no, thank you very much, you know, not just for the presentation, but for all the work. I think that all of us appreciate like how difficult it is to get to something that's robust that you trust. And then I think the big thing is, you know, a tool that you trust to be true. And I think what's lovely for Canadians, since we're on a Canadian bandwagon these days, but also that this is developed in Canada, validated in our province and in your province. So I think our confidence that these numbers are true is much, much higher. So I'm hoping that perhaps also like, how do you use this tool? Maybe some webinars or at the elbow kind of implementation might be of value, because until you use it on a regular basis, you won't even know when. And it might be worthwhile doing some like at the bedside or at the clinic side ways so that people see, oh, it is easy to use, and oh, like people do like it, you know?
Yeah. Yeah. We have done some simulated encounters with physicians to try to understand this. It does get easier with time as you become more familiar with it and you know where it's going and you're more
Yeah.
confident moving through it. So I think, yeah, it's really important. Like there is like a learning process to
That's
working
what I'm
with
thinking,
the
right? And
decision aid.
people are
Yeah.
already overwhelmed and everything. So, but if we sort of had at the
Yeah.
elbow help, kind of implementing a new information system, you have help doing it. Like, this is not so different, right? If
Yeah.
especially in these very specialized encounters, it's about this specific decision to make. It's not all of their care.
Yeah. In
Yeah.
that trial where we introduce a decision aid, we have a bit of a training program that we go through with the physician that we've been debating whether we should try to incorporate like a practice encounter with them in the beginning.
Yeah.
So
It
that's
might,
interesting to
yeah.
hear your thought. We've been trying to do people, you know, will they
Yeah.
want to
Well, again, we're at time, and I want to thank both of you for a Friday morning call, but also for the work, as I said, and to Lee and the team for helping to provide and working with the cardiac services as well, so that we actually have robust data. So thank you very, very much. Stay tuned.
Thank you, everyone.
Thank you.
Bye.
Bye.
Happy Friday and long weekend.
Yeah.